Yeah, dimmed a little bit. All right, so this is Airway Management. So, like I was saying, by the end of residency, I could kind of relate to this thinking back. So you sort of start off in the novice zone, you become an advanced beginner, then you start feeling competent, then you become proficient, and eventually the goal is for you guys to become experts at airway management. And you will think back to your first few intubations and realize that you really did start off being a novice, but it really gets a lot easier with time. And the transition, you start off sort of as this detached observer. You feel like you're just watching, trying to learn how people do things, and then over time, the way to progress is to become involved, accept more responsibility yourself. You start integrating data more easily, so the airway exam and sort of conditions, what surgery they're doing, what your different airway options are. And then at some point it becomes almost intuitive what the right thing to do is and how to do things, so it gets easier. Here's the basic outline. So I thought we'd start off with some anatomy, then the airway assessment, and then talk about some of the more basic management options. So these are always good things to quiz on for tests and boards and things like that. So anatomy, you have the nasopharynx, oropharynx, hypopharynx. Tongue, epiglottis is something important to know. Here are the vocal cords, larynx, and trachea, and then they don't label the vallecula, but it's just that right there. And I think it's useful, so as you guys move forward, just every time you're trying to talk to someone about parts of the airway, try to use the proper anatomical name, and then it sort of, you sound more professional, more like a physician. And here we have the epiglottis. That's kind of a weird view, but that's the backside of the epiglottis, a hyoid bone. It's useful to know what that thing looks like. It's a landmark for a couple of airway blocks. The thyroid cartilage, cricoid cartilage, and the cricothyroid ligament. And then this is hard to remember, but easy to test on. And it comes into play when you're thinking about how to prepare someone for an awake fiber optic intubation. Your goals, a nice way to approach it is to think of all the different nerves that you need to block to get a good sensory block. And so the glossopharyngeal nerve, that's cranial nerve 9, it's sort of the back of the tongue, everything above the epiglottis. Then you have the vagus nerve has several important branches. The internal branch, superior laryngeal nerve, and then the recurrent laryngeal nerve. So recurrent's everything below the cords, superior is everything above the cords from the epiglottis. It's hard to remember, but again, if you keep looking at it, it soaks in over time. The motor is pretty easy. There's only two. External laryngeal nerve is the only thing besides the recurrent laryngeal nerve, and the external laryngeal nerve only goes to the cricothyroid muscle, and everything else is recurrent laryngeal, so that's easy. And then, so what happens if you have nerve injuries? It's just a hard thing to remember, but an easy thing to test. Superior laryngeal nerve, unilateral, not a big deal. Bilateral, hoarseness, tiring of the voice. Recurrent laryngeal, unilateral is hoarseness, bilateral. That's the one, acute bilateral recurrent laryngeal, you can have stridor and respiratory distress. And vagus nerve, unilateral hoarseness, bilateral aphonia. This comes into play with a lot of ENT type surgeries. They can sometimes compromise these nerves. All right, and vasculature. The main point here is if you ever have to, or if they test you on doing an emergency trach, the reason to stay in the midline is to avoid all these vessels. And so if you stay in the midline left to right and the midline up and down, you should be in the clear, but everywhere else there's just tons of vasculature. All right. And this is an example of physical exam findings consistent with difficult airway. So obesity, thick neck, that's definitely one of your difficult airways to look out for. And so have you guys seen this document from the ASA? I think besides just that, so this is where they include the difficult airway algorithm, and it's obviously something that we should all be very familiar with. But if you go through and read the text, they go through a lot of other pretty good points about the airway. I just put up here different aspects of the airway exam, and as you go through training, you'll hear all sorts of ways to examine the airway. It becomes almost overwhelming. So you should know all of the exam components and know the significance, and some are more significant than others, and most of these are pretty intuitive after some time. So length of the upper incisors, and then overbite or underbite, basically. How much they can open their mouth. If you can see the uvula, which is, what's the name of that test? Yeah, right. Shape of the palate, compliance of the mandibular space, thyromental distance, length of neck, thickness of neck, range of motion, things like that. So there's all sorts of things that you can look at. Only a few things actually have been shown to indicate difficult intubation. So these are the official things that actually have really been shown to be associated with difficult intubation. Mallampati classification, thyromental distance. You guys all know what that is? Probably, yeah. Sternomental distance, mouth opening, and then combination. The best one's probably the combination of Mallampati class and thyromental distance. And then some people came up with this other risk score. So you can kind of focus your exam on things that are true signs of difficult intubation. And then just one of these doesn't have too much predictive value, but the more of these that you encounter, the higher the predictive value. This is a good picture of Mallampati score. So what position should the patient be sitting in to do this test? And then should they phonate or not?
No.
All right, yeah. And stick out the tongue? Yeah, all right. And that's what it looks like. So signs of a difficult ventilation. So different from signs of a difficult intubation. There is some overlap, but to me, this is a little bit more alarming than the difficult intubation. If you can't ventilate, you're really in a pickle. So age over 55, BMI over 26, beard, history of snoring, lack of teeth, and limited mandibular protrusion. So if they can't put their mandible forward, those are signs of difficulty. And we have a lot of patients with one of these traits. So if you see 2 or 3, that's when you really need to start worrying about things and think about how you can safely anesthetize them. And so this is an obvious point, but something I like to tell folks. There's no reason not to look at the old anesthesia records, especially now. It's all in the computer. Look at how people have managed the airway in the past. And if you do have any sort of problems, clear documentation is going to really be key. Then other components of history. So what sort of medical history is consistent with difficult airway besides OSA? Yeah, RA. What else? Yeah, that's a good one. Radiation. Have you guys had any patients with radiation, history of radiation? Was it tough? I think those are really tough. They look like they should be easy, and then nothing moves. So that's a good one. Yeah, C-spine trauma. Any surgical history that should be alarming? For the airway? Like patients had this type of surgery 2 years ago, or 3, or whatever. Like neck fusions, and obviously like neck dissections and flaps and things like that. All right, here's another example of difficult airway, acromegaly. This is a picture of a guy that has a pituitary tumor, and that's how his facial features have changed over time. They can be, at this point on the far right, he's probably pretty difficult intubation, and probably potentially difficult ventilation as well. All right, so it sounds very basic, but mask ventilation, I thought we'd start there. Obviously, it requires a tight mask fit and a patent airway. And then if you think back to the risk factors for difficult ventilation, beard, lack of teeth, it correlates with these two fundamental necessities for mask ventilation. So what happens to the airway as you become anesthetized? It collapses, right? So the loss of muscle tone, that's the muscle they're talking about, is the genioglossus. You can see on this picture that the tongue falls back. And believe it or not, things that we do, it'll get to the point of becoming intuitive, like you'll see, but what we are very good at is relieving this upper airway obstruction. So all those things that you guys have been doing, so putting in nasal airway, oral airway, jaw thrust, chin lift, sniffing position. Really the whole point of that, for the most part, is to just open up this obstruction that happens every time we anesthetize people. And the other thing is, it's not really, there's no particular anesthetic that's worse than the others, it doesn't seem. So it happens with propofol, it happens with sevoflurane. It just, as this muscle tone relaxes, you obstruct the upper airways. And then the deeper under anesthesia you get, the more of the collapse there is. And then, I don't know. Obviously, you guys are going to get you probably are very familiar with how this APL works and what you're doing. But I just thought it's nice to step back and think about what you're really doing. So what happens when you're squeezing the bag and holding the mask? With the APL, it's different from an ambu bag, right? Because when you squeeze the bag and you're dealing with an APL, if you have a tight mask fit and you have high fresh gas flows, when you squeeze the bag, you're not changing the pressures. It's when you release the bag, that's when they exhale. With the ambu bag, when you squeeze the bag, that's when you deliver your positive pressure breath. And same thing with how you add PEEP to your management. So PEEP is a good way to open up those upper airways. How do you dial in PEEP with the APL? You set it to 5, so that's the baseline pressure, even as they exhale. But with the ambu, you have to have this little thingy on the top. Do you know what this picture represents up here? Why it's in the anesthesia patient safety newsletter?
Somebody long exploded.
It's a good guess. No, so yeah. So what can happen is, especially like the CO2 sample line can get stuck underneath these things, and you won't be able to dial down the APL valve. So you won't be able to dial in a pressure to your APL, and you won't be able to deliver breath. All right, probably seen this. So this is the classic sniffing position. The reason for doing this sniffing position is to align these 3 axes and optimize your view through the mouth to see the chords. But it's different for obese people, right? So have you guys usually sort of ramped up the backs for obese patients? Does it help? I think it helps a lot. So the goal, has anyone mentioned how you know if you're ramping them up properly or not? Yeah, so like the mastoid process to the sternum, basically. And it makes a huge difference. This guy bears close resemblance to a difficult airway I ran into in residency. So I was called to intubate a patient in the ICU, and they're always falling in the beds, you know. So it boils down to good positioning. So you wouldn't want to manage this guy's airway without doing something first. All right, pre-oxygenation. It's something you do almost intuitively, but there's people have studied it. And there's a certain way to do it optimally. Pretty much consider it desirable in all patients. So how do you know when you have pre-oxygenated the patient? End-tidal oxygen of 90% or better, or end-tidal. If you could measure end-tidal nitrogen, that's why. Has anyone called it denitrogenation? Yeah. So same thing. So if your goal is to get introduce oxygen to the patient and wash out the nitrogen. So if you can get the end-tidal nitrogen down to 5%, the patient is pre-oxygenated as well. Two common methods: tidal volume breathing for 3 to 5 minutes, or deep breathing for 1 to 1.5 minutes at 10 liters of fresh gas flow. And what you really want, so what determines the speed of pre-oxygenation is what you're going for is raising the oxygen levels, decreasing the nitrogen levels in the functional residual capacity. And so the main determinant of that is your minute ventilation to FRC ratio. So if patients don't have much FRC, are they going to desaturate fast or slow? Fast. But they'll pre-oxygenate fast too. But it just won't help you very much. If breathing really slowly, obviously it'll take longer to pre-oxygenate than if they're breathing quickly. So that's this ratio. So I thought this was a pretty good slide. So Benimoff, I think this is from a computer model of desaturation. This furthest out line is a normal 70 kilogram adult. This one's moderately ill, which is probably most of our patients. Then children and obese adults. So he calculated if you have a good pre-oxygenation, how long does it take for the sats to drop? And you can pick your number. So let's say 90%. You've got about 8 minutes in a normal, healthy adult. And how long does it take for 1 milligram per kilogram of succinylcholine to wear off? ASIN. So 50% of mean of recovery of twitch height is like 8.5 minutes. So a couple of things. So with a good pre-oxygenation, you have a fair amount of time, but you still might desaturate if you're waiting for your sucks to wear off. All right. So pre-oxygenation. So faster desaturation with pregnant patients, obese patients, and patients with lung disease. That makes sense. Pregnant patients and obese patients have a low FRC. Patients with lung disease just don't oxygenate very well. So elderly patients, they have lower oxygen consumption. They have less efficient uptake. So it takes longer to pre-oxygenate, but also longer to desaturate. So you've got plenty of time with elderly folks. Pediatric patients have small FRC, high oxygen consumption. They're pretty quick to pre-oxygenate, but they're also very quick to desaturate. All right, so pretty basic what you guys have been doing every day, mask ventilation. This is a pretty good picture of a one-hand technique and two-hand technique. And there's some ways to alter this, but the main thing is you want those two things. You want an unobstructed airway, you want a tight mask fit. So the pointer finger and the middle finger pulling together brings the mask to the face, and then the pinky finger brings the jaw forward. And with the two-hand technique, you get the jaw forward and the mask to the face. And then airway devices. So you've probably been told if you have difficulty ventilating, one of the first things you do is oral airway or potentially a nasal airway. Do you know how to guess what size oral airway to use? mouth to angle of mandible. You just hold it next to their face and make sure it looks like it's the right size. And then there's two recommended ways of inserting. So you can insert it upside down, start inserting, and then flip it, or you can use the tongue depressor method, just insert straight. Nasal airways. So here's from the nose to the ear canal. That's sort of a way to estimate what size nasal airway you need. And this is a funny looking picture, but it makes the point that you're not inserting this to the brain, you're inserting it straight back. And the goal is to just make some sort of passage behind this tongue that presumably is flopped back and is obstructing your ventilation. Contraindications to nasal airway: skull trauma, big adenoids, and anticoagulation. And has anyone done nasal intubations? Yeah. Did you get caught up when you put the tube in the nose?
Yeah, a little bit.
Yeah.
Straight in.
Yeah, so it's right back here, and that's sort of the adenoid area. So that's the same thing that can sort of get in your way with this nasal airway. And then the laryngeal mask airway. This is one of the most difficult airways I've ever encountered. Not this particular patient, but someone with the same disease. He had epidermolysis bullosa. It's a disease of the connective tissue, so their skin sloughs off with even the slightest touch. And so over time, they become very scarred and stiff. The same thing with radiation. So this guy's having radiation to his neck, and I bet you he doesn't move his neck very well. So it might not look like a bad airway from the outside, but when you get down to it, you might not be able to open the mouth very well. You might not be able to pull get very good exposure with the laryngoscope. All right, LMA. Everyone's been using this, I presume. It's regarded by many as the most important development in airway management in the past however many years you want to say, 30 years. Does anyone know any rock-solid indications for an LMA? I couldn't think of any absolute indications for LMA. But we use it a lot, and I would say, at least in the beginning, I would call it basic use of the LMA. You want to select the right patient. So non-emergent, ASA 1 or 2, low aspiration risk, routine short procedure, and people have different cutoffs. So it depends on the patient's health, but 2 hours is probably a reasonable cutoff. Surgery excluding airway and GI tract, spontaneous ventilation, and supine position. This all makes sense. So I think if you have the right patient, it's worthwhile at least saying, well, I think it's safe to do an LMA for this case. Poor candidates. So full stomach. So this thing doesn't, no one would ever claim that an LMA protects against aspiration, right? So full stomach, so no. Obesity. Why might obesity be difficult? Because they might benefit from so they'll have a low FRC. They might have some atelectasis. The SATs will be low because of the atelectasis, and then you don't have a very good way of giving reliable positive pressure breaths to relieve the atelectasis. Pharyngeal abnormalities and restrictive lung disease. Restrictive lung disease for the same reason. If you wanted to deliver positive pressure breath, you would need high pressures, and you're not protected against filling the stomach, etc. But the real beauty of the LMA are some of these advanced applications. So it's a nice way to introduce a bronchoscope. Has anyone put a bronchoscope through an LMA? So it's a nice big hole, so it's easy to put the bronchoscope through, and usually by the time you get to the end of the LMA, you're looking at cords, and you can just go right into do whatever you want to do, if you want to intubate or whatever. Some folks have advocated its use in non-supine patients. I've been told that it works pretty well lateral. Some folks use it prone. It's an excellent conduit for intubation. So we'll look at the difficult airway algorithm, and it says, at some point it says, if it's a difficult ventilation, consider placing an LMA. And then if you can ventilate with the LMA, there are ways to intubate through the LMA. And then ENT surgery, people have used it for tonsillectomies and things like that. But I would call these advanced applications. Anyone know who invented the LMA? Dr. Brain. So this guy, over years and years, just sort of fiddled with these models of masks and tried them out on patients, and eventually came up with what is basically the LMA. And over those however many years, he basically used this device on thousands of patients. And so what I'll run through is his way of inserting the LMA. He says, deflate the cuff. And then also they sort of describe this as the way you insert the LMA mirrors how people normally swallow. And so what you do is you run the LMA up along the top of the palate and then down into the back of the throat. So deflate the cuff completely, lubricate the top of the cuff right here, flatten the mask against the hard palate, and it's a cranio-posterior movement of the index finger. So the way they tell you to hold it is with your index finger on that part of the LMA. You just run your finger up the hard palate. And then with the other hand, you push caudally on the back of the head to open the mouth. And here's a picture of the finger sliding up the hard palate. And then the goal is for this tip of the LMA to go into the top of the esophagus so that the whole of the LMA looks right at the vocal cords. So that's the rationale for making this sound like swallowing, because you want it to end up right with the tip just at the esophagus. Stabilize the LMA, remove the index finger, inflate the mask, and fix the device with tape. Here's another difficult airway. That's a syndrome called Treacher Collins. They have just very small mouth anatomy. So here you have a short thyromental distance and probably pretty difficult intubation. So Dr. Waters, has anyone read this chapter yet? So he talks about the indications. So this is an excellent textbook. It's enormous, but it goes into all aspects of airway management. And if you want to read about indications, chapter 15. Then we talk a little bit about just your basic endotracheal tubes. High volume, low pressure. Pretty much any cuffs that we have nowadays are high volume and low pressure. It's just, they always say that because years ago they had low volume, high pressure cuffs. And the problem with that is that the high pressure on the tracheal mucosa can cause ischemia, scarring, and then tracheal, further down the road, edema, and then tracheal stenosis. The size that we talk about with these tubes is actually the internal diameter in millimeters. It's like a 702 is 702 is 7 millimeters on the inside. For most purposes, females 7, males 8. This is one estimate of insertion depth. Females 21 to 22 centimeters at the teeth, and males 23 centimeters. That doesn't mean that you don't have to listen to breath sounds and everything. It's no guarantee. And then, same with anatomy. I think it's useful when you're talking about parts of the equipment to use the proper name. So the tip of the tube has a bevel, which means that it's sort of pointy, and that's to help it. The reason for that is so that when you go between the cords, it just sort of slides in between. There's a Murphy eye at the tip. That's the second hole on the side, and the reason for that is if you didn't have it and the tip of the tube was up against some, let's say the carino, that you could have a complete obstruction of your endotracheal tube, and this Murphy eye will at least allow some ventilation. And then the balloon is, the proper name is a pilot balloon. Alright, probably heard many ways of confirming placement. The best way is direct visualization to the cords and persistent exhaled CO2. There's a whole bunch of other stuff you can do. You can look for the condensation, you can listen for breath sounds, chest wall observation, palpate the cuff at the neck. Has anyone done that? So the idea is you palpate the trachea right above the sternal notch with one hand, palpating one hand, feeling the pilot balloon. And as you push on the trachea, you can feel the cuff go up and down. Chest x-ray, fiber optic exam. So if you really don't know what's going on, you can put a fiber optic scope down, look for tracheal rings, and that should be pretty reassuring. At the same time, you can do a transtracheal illumination. So you put a flexible light down the endotracheal tube and look for that light on the trachea. Anyone know what the self-inflating bulb refers to? Yeah, I guess so. A baster would work. So it's helpful if you want to know if you're in a So if your tube is in the trachea and you put a self-inflating bulb on the endotracheal tube, it will suck air out and expand on its own. If your tube is in the esophagus and you put that bulb on, it's just going to collapse the esophagus and it will not self-inflate. Pulse ox eventually will tell you if you're intubated or not, and then some method called acoustic reflectometry. Alright, blades. So this is your Macintosh blade, that's your straight Miller blade. This is from that Benemoff textbook, so just some of the basics of how to intubate, but if you don't know it, it's worth knowing. So there's several ways of opening the mouth. This one's probably the most common, called the scissor technique. Alternatively, you can just get the laryngoscope, tilt the head back to open the mouth, get the laryngoscope close, and then with your pinky finger, get the lip out of the way and open the mouth that way. The epiglottis is one of those key structures. With the straight blade, the idea is that you retract the epiglottis, as in the top picture. With the curved blade, the goal is to get the tip of the blade into the vallecula, so that you should still have the epiglottis in view. And just sort of the basic steps of intubating. So insert the laryngoscope blade into the right side of the mouth. Sweeping the tongue to the left is crucial. You want to look through the mouth at the tip of your blade as you advance into the vallecula. Once the tip of the laryngoscope is in the vallecula, that's when you lift the laryngoscope away from basically towards the feet and expose the vocal cords. So it definitely is, and the 2 points that I think are useful for repeating is getting the tongue swept to the left and watching everything as you advance the laryngoscope down into the vallecula. And this is sort of what happens if you don't get good tongue control. So picture on the left, the tongue is swept, on the right it's not. Has anyone seen that? That's the esophagus. So it just looks like a round, dark hole. You don't see any sort of cords or arytenoids or anything like that. So some of my tips. So careful positioning ahead of time. That can make all the difference in the world. Stay off the teeth. The lips and tongue can get pinched pretty easily, so you've probably run into that, and I know I've done it a lot. So you're focusing on the trying to see the cords, and you don't realize that the bottom lip is caught between the laryngoscope and the teeth. You want a nice wide mouth opening, and you really want to get the tongue out of your way. And then if you find yourself struggling, don't lose sight of what else is going on. So reevaluate positioning, the tongue, all the most common things that could be getting in your way. Make sure you aren't about to break some teeth, and think ahead to what's, if this isn't going to get any better, what's your next step? Are you going to come out, put an oral airway, ventilate, change your blade, change positioning, get an LMA, call for help, use a fiber optic scope. And I can remember when I was starting off with intubating, if it was difficult for me to get a view, I thought it was my fault, and I'd want someone else to jump in. At some point, probably before you realize it, it'll get to the point where you guys are very good at intubating, and if you're having a hard time, there's probably a good reason for that hard time. So it's either the patient's not positioned well, or it's a difficult intubation, a true difficult intubation. You guys pretty familiar with the classification of the airway exam? So when you are doing your direct laryngoscopy, so this goes back to the same thing. So if you don't get a good view with laryngoscopy, at some point it's not you, it's a difficult laryngoscopy. And it's important to document that in the chart for the next person. And grade 1 or even grade 2 is it's pretty usable. Grade 3 and 4, you're kind of taking a leap of faith if you're going to put a tube down. So a few people have done nasal intubations. You did one? Yeah. Do you know what these are? Yeah. So let's say and what kind of case was that? Yeah, so ENT and dental procedures, those are sort of the classic nasal intubations. So read about it, read about contraindications for those. And as you're preparing, remember to use a vasoconstrictor to the nose, ideally while the patient's awake before you head back to the OR. If you do that after induction but before paralysis, you could cause a laryngospasm just by putting that stuff down the nose. Lubricate the tube. Did you warm the tube up for that?
I did. I think someone else did.
Okay. Yeah, it seems to help. So if you get warm saline from the core, you can put your tube in there and it gets a little softer. And the key, so you kind of need a good laryngoscopy view, and then when you grab the tube with the McGills, leave some distance at the tip of the tube so that when you lift it up and put it between the cords, you actually have something to stick between the cords. You know what I mean? You can't put the McGills in between the cords. You gotta have a little distance between the McGills and the tip of the tube to place in the cords. Flexible fiber optic intubation. I decided not to talk too much about this. Have you guys gone to the Sim Center for airway stuff yet? Some people, not everyone. So it's an excellent course, and they'll talk about a lot of the details about flexible fiber optic intubation. My only advice is don't rely on anyone to set up all of your airway equipment at all. So check the laryngoscope yourself, make sure the light works. But in the same sense, make sure that you know how to set up a fiber optic scope and make sure it's set up properly before you bring the patient back. And then we're all a little bit different, so attendings are all different. Just talk to us ahead of time, make sure you know what we expect. You can do it nasal or oral, you can do it awake or asleep. And there's lots of crazy techniques to intubate patients, or even just basic airway management. There's all different options, so just master the basics at first. Likewise, there's tons of complications. Anyone had any good complications yet? Yeah, so that's a good one. Laryngospasm, bronchospasm, etc. One of them is a failed airway. We didn't always have this algorithm. And failed airways still is a reason why anesthesiologists get sued for a lot of money. So to help folks, the ASA came up with the difficult airway algorithm. And it's more than just what to do if you can't intubate and can't ventilate. Starts off with assessment, assess for difficult ventilation, difficult intubation, patient cooperation, or difficult trach. And we talked about difficult ventilation and intubation, so that's it's basically just do the exam and look at the history. And then give oxygen throughout the process. And so those two little points up there are pretty easy to forget, but they're key. Then think about your options: awake versus asleep, spontaneously breathing versus controlled breathing, or just go straight to invasive techniques like a trach. And then spend some time looking at this algorithm if you haven't already. Key points: if you get into the situation of difficult ventilation, then you're in emergency. But if you have difficulty ventilating, place the LMA. And then if the LMA works, you buy yourself some time. Laryngospasm. So what's the cause of laryngospasm? Anyone? Yeah. What state of anesthesia is the classic too? And then it can happen during induction or emergence. How do you know? What does it look like if someone's having laryngospasm? How do you know? So what? Right, yeah, all those things. So you have upper airway obstruction, so the cords are spasming closed. If they're trying to spontaneously breathe, it'll be a paradoxical motion of the chest. So they're tugging against the closed glottis. And if you're trying to ventilate, your peak airway pressures are going to go up. It probably won't be on the ventilator per se, but as you're trying to deliver positive pressure breath, you're going to be struggling. And how do you treat? What do you do? 100% oxygen, positive pressure. Yeah, you can deepen the anesthetic. Ultimately, succinylcholine. What about jaw thrust? Why does jaw thrust help with the laryngospasm? What's the? Yeah, but more so than just opening the upper airway, but you're putting some tension on the actual muscles that are spasming, and the hope is that by itself will also open up the cords. And then what's the dose of sux for laryngospasm? 20 milligrams? Right, for an adult, yep. So that's the official dose. If you're going to wind up intubating anyway, you could just give an intubating dose. All right, esophageal intubation or a bronchial intubation. I think we talked about, so esophageal intubation, anyone done that? I think we all have. So you put the tube in and it doesn't feel right when you squeeze the bag, you don't see CO2, there's no, just like that self-inflating bulb, there's no exhalation, or you don't get much exhalation. So you squeeze the bag and nothing comes back, and the chest wall isn't moving, and you might hear some gurgling. It just doesn't seem right. If that does happen, has anyone left the tube in and then put the blade in to look for the second attempt? Or you just pull it out pretty much and mask? So if the patient is not desaturating and you recognize an esophageal intubation, you can put the laryngoscope back in, and then that existing tube can at least act as a place marker for the esophagus, and you go just anterior to that. Most of the time they're starting to desaturate and you need to mask ventilate a little bit before re-intubating, but it's something to think about. How does head flexion and extension, how's that related to bronchial intubation? Right, so flexion pushes the tube down, extension pulls the tube up. Good. Negative pressure, pulmonary edema. You guys know what that is? So what are the scenarios where that can happen? So laryngospasm is one. So laryngospasm, oh, sorry. So biting the tube. So ways to prevent that. So we talked about laryngospasm, and then ways to prevent biting the tube are just, if the patient can bite the tube, might as well put something between their teeth so they won't bite the tube. Has anyone seen negative pressure pulmonary edema? It can be terrible. Yeah, so they have to be strong. To really hurt themselves, they have to be strong enough to generate a strong negative pressure breath. So, it's like classically the teenager that bites the tube, tries to take a big breath, has terrible pulmonary edema, the SATs will be in the pits, and everything went fine except they need a non-rebreather. That sucks. Accidental extubations. I think it speaks for itself. That's something that we need to vigorously prevent. And that's always the center of your attention in the OR. Other complications, laser fire. Has anyone done a laser case? So there is a laser tube, right? Did you use a laser tube for that? It's not a surefire guarantee that you won't have a fire, but it certainly helps. And then did you decrease the FiO2? Yeah, so get the FiO2 down as low as you can for those. That's the idea of the laser fire. What happens if they accidentally laser your endotracheal tube and it catches on fire? And turn the oxygen down, pull the tube, and reintubate as soon as you can, right? Because it's just, that airway is just going to get nasty after that. Jet ventilator. Has anyone used the jet in the OR? It's kind of a ENT thing. So before you do one of those cases, spend a little bit of time reading about complications, equipment problems and failures. Has anyone had any weird equipment failure? So you can have anything from rare things like a unidirectional valve failure to circuit disconnect, which I'm sure, if it hasn't happened, it probably will happen at some point. To the ventilator not working right, or somebody didn't seal the absorbent in properly so it leaks. You name it, it could happen. Traumatic intubations. When you look at a list of complications, there's about 20 different structures that can be traumatized during intubation. From the most common of teeth to nerves, blood vessels, you name it. All right, so there's also an airway rotation, and it's one of your rotations. It was new last year, so this is the second year that we've had the rotation. It's one of the general surgery rotations that you guys have, and it's sort of a dedicated time to focus on these alternative methods of intubating. I think the idea was that folks weren't getting enough opportunities to do elective fiber optic intubations or using the bougie or the fast track LMA. So this is dedicated time to just do whatever you want. That said, you can't just, if you're doing an ortho rotation, all you have to do is show up and do ortho cases. But this, you have to take some initiative, plan ahead, look at your patients and think, what can we do for this guy? Is this a good case to do an elective asleep fiber optic intubation or a fast track, or should we just, does he maybe have a little bit of lung disease, should we just use a bougie, something like that? But and then you have to tell your attending that you're on the airway rotation, you have to do all these other things. And obviously it's easiest if you have all the equipment set up in advance, and like I said, choose the proper techniques. And then this was the list of procedures that they came up with that seemed good to me. I added nasal intubations, but I'm going to talk to Dr. McAvoy about maybe not having that on there, because it's either you can do them or you can't. It's hard to do an elective nasal intubation on someone that doesn't need it, because it's pretty common to get nose bleeding and it's hard to explain. But this is something I try to email you guys when you start the rotation of some guidance about the rotation, and then I have this little chart on there, and just keep track of what you've done during your rotation. So we said 8 fiber optic intubations, 4 intubations through LMAs. The easiest way to do that is with the fast track LMA, which is in every room. 8 rigid video laryngoscope guided intubations, so that's the glide scope. That shouldn't be an issue. Does everyone use the glide scope? That's very popular. And 8 intubations over tracheal tube guide, and the most common one of that is the bougie, which is also in every room. So really the fiber optic and intubating LMA can be the most labor intensive for setting up and doing, and you could do them together. You could do a fiber optic through the fast track LMA, which I think is worthwhile doing if you haven't. And then this is not a difficult airway rotation. This is not an ENT rotation. The idea, and not, so things to look out for, make sure you're getting fairly healthy patients with fairly routine surgeries where you can do an alternative intubating technique. It shouldn't be the neck dissection with a giant tumor that you have to really worry about, or somebody who you have to do awake fiber optics. You should not run into too many true difficult airways on that rotation. That's it. Is there any questions or stories?